So today we are indeed very privileged to have a very special faculty with us. Dr. Lorenzo Berra, sir is at Harvard Medical School, and he is very well known to us for his book, The Critical Care Handbook of Massachusetts General Hospital, which most of you have read, and indeed even I had read at one point of time. Sir is an anesthesiologist and critical care physician, medical director of respiratory care, and Reginald Jemmy Associate Professor at the Massachusetts General Hospital, Harvard Medical School. And it is indeed a very great privilege today to have him with us. And today is also our 200th webinar, a bicentennial webinar, and that indeed makes it even more special. So with that, I hand it over to you, sir, to teach us about obesity, ventilation, and the future with the patients who are obese, because that is, what we are looking at, the epidemic of obesity.
So welcome to everyone. Today I'm going to talk about mechanical ventilation in patients with obesity. And the reason, and this is my conflict of interest I'm placing there. There is nothing related to the presentation I'm giving to you today, but the studies I will present, some of the studies I will present are supported by our department and from Harvard Medical School. So the prevalence of obesity in India, of course, is one of the lowest in the world. As you see in the United States, where I live, in Boston, we are about 40% of the population. But areas like some part of Europe and Asia, India, China, there is the lowest prevalence in the world. However, the prevalence is increasing. This is a kind of very a paper that just came out a few months ago, showing that in fact from 1999 to 2021, the obesity both in men and women in India has been increasing, as shown by the graphs. So it's about still very low. It's about like anything that is between 5% to 20%, but there is this trend. So it's something that we need to consider. And why it's important? It is important because, in fact, the obesity is related and correlates strictly with mortality. This is a study that was published on Lancet, probably the largest epidemiological studies that has been reported. It's about 10 million people, and they followed the subjects for 5 years. And what you see is that there is a U-shaped mortality, where the lowest mortality is in around 20-25 of BMI, but increasing at about 30 and 40 of BMI. The hazard ratio is doubled or tripled. And this is independent from the continent. In Europe is the same, North America, South America, Asia, and South Asia. So it doesn't really matter the continent and the countries, as well as it doesn't really between the difference between genders is exactly the same. So here you see men and women, and there is the same shape, U-shape, increasing in mortality at higher than 30 of BMI. And here again, also based on age, there is no difference. There is always the same reported mortality. When you think about what are the causes, and clearly here it shows that respiratory conditions and coronary artery disease are the leading causes of mortality, the drivers for mortality in this patient population. But some would say, okay, what about ICU patients and ICU mortality? And here you see this is one of report back in during a COVID time, but it's about 150, close to 150,000 in the United States ICU patients with COVID that were ventilated. And here you can see that there is still the same trend. When a 30 or 40 of BMI is reached, there is an increased risk. And doesn't matter whether it's in ICU admission, whether they are receiving, when they receive mechanical ventilations, this risk is, of course, even accentuated, and the mortality is increased as well. So once there is lots in the literature about obesity paradox, but I would say that we need to be very concerned and very careful to talk about obesity paradox when it's clear that in large trials and large epidemiological studies, this trend is robust, and there is the correlation between obesity and mortality is extremely elevated. There is lots of history about, fashion forms of, like, they are happy because they eat lard, and all the beautiful images around back in the even smoking was considered something great, but needed to be very cautious about considering this idea of obesity paradox that reduce mortality, because the reality is that in fact mortality is increased also in the ICU, also among patients that are mechanically ventilated. So what do we learn from these first epidemiological studies? One is that obesity kills, and that we need to be very careful when we read in the literature about obesity paradox. It's not true. The obesity is, in fact, is increasing even in India, but as well as in many countries. Of course, in the United States, it's something that is it's a endemic, but also in the other countries, that's true as well. So, what are the implications for the ICU physicians? So, my goal today is to talk about three parts, let's say, of my presentation. One is the airways closure. So what does it mean to have airways closure in patients, and what is the importance of airway closure when we think about cardiopulmonary physiology in patients with obesity? The second will be lung atelectasis, and what is the role of lung atelectasis? How do we prevent it? And then last, the effects of positive pressure, so mechanical ventilation, positive pressure, on hemodynamics. So I will start with airways closure. This is a study that was published by an Italian group led by Domenico Grieco. These are patients that they have normal lung function. They are in the operating room. And what they did was to ventilate them and then start a low flow inflation. So here the flow on the ventilator is about 1 to 2 liters per minute, continuous flow. And what you see here is that there is an increase in airway pressure. So this is a normal dynamic, and there is no airways occlusion. There is a different changes in pressure that is that will provide you the compliance of the respiratory system. What happens in patients with obesity? Patients with obesity, what he observed was that when you start the low flow inflation, then there is a rapid increase in pressure, which is which basically reaches this that is called AOP, which is airways occlusion pressure, which is when the airways are stand open, and then the pressure is increasing as the tidal volume is increased. So this is this pressure is used by the ventilator to actually reach an opening pressure. And here again, in patients with actually the ICU, patients with ARDS, this is from a French group from Rémy Condron. What he did was to do similar study, but in patients with ARDS without obesity and with obesity. And what he found was that by increasing slower the pressure, there was an increase in volumes in the lungs of this patient. But you see here instead, when there is an increase slow in pressure, up to 15 centimeter of water, there is not increasing volume, which means that the entire airways are occluded and closed. Only above 15 of centimeter of water, there is air entering the lungs, so overcoming the airways opening pressure. In this study, what he tried to do was dividing groups of patients with ARDS by BMI. And what he tried to do was to divide patients that were below 30 of BMI, between 30 and 40 BMI, and above 40 of BMI. And what we found was that the driving pressure was actually high in those patients with 40 of BMI, but some part of the driving pressure was due to just opening those airway pressure. This is important because sometimes we label patients with ARDS, but possibly it's because actually it's a misnomer, because maybe they have atelectasis or they have airways occlusion. So we needed to really be aware of this phenomenon. So because there was not much in terms of there is not much literature in terms of how individuals with obesity are breathing, what we did was to do a physiological study. And so we asked to individuals with obesity to come to the hospital, and we studied their airways, their pulmonary function, and their cardiac function in response to positive pressure. So, and then we decided to optimize airway pressure according to esophageal manometry. And we chose to use esophageal manometry because it's the most close proxy that we have in order to measure pleural pressure. And so we could calculate the transpulmonary pressure, which is the pressure across the alveoli, that is airway pressure minus pleural pressure, in order to maintain an equilibrium across the alveoli. This was our setup in the laboratory. We use electric impedance tomography, which is a non-invasive machine to determine ventilation inside the lungs. We recorded continuously esophageal manometry, and then we use CPAP systems to determine what was the response to the respiratory systems. And also we did echocardiography in order to determine right heart function in response to changes in airway pressure. This is how a normal weight individual is breathing. So there is an opening glottis and there is a negative. This is an esophageal manometry trace. And at the end of exhalation, if the individual opens the glottis, this is what you see. And this changes in small changes in pressure is basically it's the cardiac activity. But as you see, there is about 4 centimeters of water in this individual, which is the esophageal manometry. And in order to maintain 0 transpulmonary pressure in that individual, we needed to put 4 centimeters of water. What we did was to divide and to enroll 18 individuals, normal BMI in 6 individuals, with a BMI between 40 and 50 of BMI, another 6, and more than 50 of BMI, another 6 individuals. What we found was that, in fact, for normal individual, a CPAP of 5 centimeters of water was enough to maintain a transpulmonary pressure equal to 0. And that is intuitive, and that's also why, for example, in the operating room, most of anesthesiologists keep a positive, just a slightly positive positive end expiratory pressure, about anything that goes from 3 to 6. In patients with morbid obesity, instead, their esophageal manometer showed that on average there was a negative pressure of about 12.5, which is what they needed to maintain a positive transpulmonary pressure. And in individuals with super obesity, they had to increase it to 18 centimeter water to maintain a zero transpulmonary pressure. Here you see some traces. I don't want to spend much time, but here I wanted to show you how in a normal individual, this is a pleural pressure, so it's an esophageal manometry trace at zero of a positive atmospheric pressure, and in blue there is the airway pressure. And here at 6 centimeter of water, you can see the transpulmonary pressure is zero, where esophageal manometry is equal to airway pressure. And on the right, there are the swings of there is the flow and the esophageal manometry. And this is an individual with 24 of BMI. When you have an individual with about 60 of BMI, as in this example, you can appreciate the large swings of esophageal pressure, which means and translates in a very large swings in pleural pressure. That is really the work of breathing that the individual has to do each breath in order to move air in and out of the lungs. You can appreciate also that the level of resting esophageal pressure in this individual before starting an inspiration effort is about 24 centimeters of water, which is the pressure that we titrated in this second part of the slide. That is the pressure that we titrated the CPAP in this individual at 24 centimeters of water. And you can appreciate also the reduction in swings esophageal pressure, which correlates to a reduction in work of breathing. And here you have basically a motion of an individual that is breathing at about 23 with a BMI of 62 with at atmospheric pressure. And then when we added 23 centimeters of CPAP and the reduction in work of breathing, and the patient and the individual was much relieved by the positive pressure. So from this study, what I wanted to emphasize is the role of airway pressure or airway closure. And as you notice is that most of the individuals with obesity that has normal lungs, there is always a component of airway pressure that is actually that is causing an increase in airways occlusion. This is true also in this study from Arnaud Till that came out a couple of years ago on the Blue Journal. What they found was that in fact, when they were considering only those individuals with a high BMI, CPAP post-extubation in critically ill patients improved the reduction in reintubation, suggesting that airway occlusion and suggesting that CPAP is necessary after extubation in this individual if we want to reduce reintubation and failure to extubate in these individuals. This is true also in a large study that this is a postdoc from Lancet Respiratory, and actually this is the prospective study from the Young that came out a year ago to reduce to improve in fact the respiratory mechanics in these individuals. Very nice study from a multi-randomized trial from France. So the second part, the second aspect that I think it's very important when we consider ventilation of obese patients is a lung atelectasis. And I wanted to go back a little bit about my history. I went to I'm from Italy, and I went to the United States to do my residency, and then I remained to do my fellowship in critical care, and then I remained on staff. But what I was very impressed at the beginning when I started to work in the ICU was the number of patients with hypoxia. And they were mostly related because of the obesity. And the problem with that was that it was difficult to win these individuals. Then they had a high mortality, and it was very challenging also to study them with like a CT scan, or because it was difficult to transport this individual to the CT. This is one of my patients. It was a 700 of BMI, 700 of pounds, about 300 kilos. And you can appreciate that this individual didn't have ARDS. They were large atelectasis. And despite being ventilated, we've considered as an ARDS patient. In fact, probably the positive pressure was underestimated, and what needed was just improving positive pressure in this individual. What was impressive to me also was that according to whether I was in the operating room or in the ICU, we had a different way to maintain these individuals. In the operating room, we keep them very in a reverse Trendelenburg at intubation, because we wanted to avoid their recruitment. We use high PEEP, and we avoid the opioids, and we use a non-invasive ventilation and extubation. Something that we were not doing at that time in the ICU. So I was wondering how and what was the underlying cause, and whether we were doing something correct in the operating room or in the ICU. That questions triggered this study that was performed by one of the ICU fellow at that time, Dr. Pirone, who basically what he did was to study patients, critical ill patients, but without ARDS. And what he wanted to do, understand, was whether there was a best PEEP that would avoid hypoxia in these individuals, and how to titrate the best positive and expiratory pressure. We use three methods. The first method is the Loring-Talmor method. I call them that in that way because clearly they have been the two respiratory physiologists, the most pronounced physiologists on transpulmonary pressure. And what they suggest was to use, in fact, what you see here in the black traces, you see an esophageal manometry, and in the blue trace there is the airway pressure. And this is inadequate PEEP. You wanted to have positive or zero transpulmonary pressure, as indicated in the second graph. The second strategy was to use the Lachman, so open lung strategies. We did a recruitment maneuver to then do a decremental PEEP trial, so measuring best compliance at each level of positive and expiratory pressure. In this example, for example, we have a best compliance around 13, 14 centimeters of water. We use really the reverse of compliance, which is elastance, but basically it's the same, it's stating the same thing, which means that the best elastance is the lowest level, which indicates the best compliance. We enrolled 14 individuals with a BMI about 50. And what we found was that the clinical ICU PEEP in these individuals was about 11.6 centimeter water. The transpulmonary pressure based on esophageal manometry in this individual was about 20, and the best decremental PEEP trial instead was about closer to 21.3. As you can see in this graph, in fact, that the positive transpulmonary pressure and decremental PEEP trial were very similar in terms of positive and expiratory pressure. Interesting, however, this was very, very unexpected at the beginning, but now it's very clear after so many studies that we and other groups have done, is that the chest wall compliance in these individuals is normal. There is no altered chest compliance. The chest compliance, in fact, it's very compliant. So here you have the elastance, which is low, which means the compliance is normal. What is impaired instead, it's a lung compliance, and that is due to atelectasis. So the elastance is increased because of the atelectasis of the lungs. So, but from this study that in critically ill patients, we found that routine PEEP level were insufficient in patients with obesity. The chest wall in obese patients is unaltered. This is a very important message from lung physiology in these individuals. It's lung elastance that is altered. It's a lung compliance that is altered, not the chest wall compliance. Recruitment maneuvers were necessary to reopen the lungs, and again, there was not really best. There was either after recruitment maneuver, there was not PEEP titration techniques that is superior. One could use a decremental PEEP trial. Others can use also pleural pressure by esophageal manometry. That is actually very good for this patient population. But as you noticed, we found that very high levels of PEEP were necessary to reopen the lungs and to overcome the airways occlusion in these individuals. However, we know that also high levels of PEEP is actually injurious. And so the question is, what is the level of PEEP that in this individual can cause atelectasis, atelectotrauma, hypotension, and volotrauma? So we had to go back really to other methods to help us out to determine whether the lungs were overstretched and whether we were at risk of causing atelectotrauma, volotrauma, and for example, also pneumothorax. So we implemented electric impedance tomography. One could use also lung ultrasound, sometimes a little bit more cumbersome to use lung ultrasound because of the size of the chest. We decided to use impedance tomography, which is really it's a band around the chest that is placed, and by impedance signal, it shows basically where the volume and where the lungs, how the lungs are ventilated. And here you have, for example, two cases from the literature. This is from Marcelo Amato group from Sao Paulo. You have a selective intubation. You can actually appreciate that there is only one lung that is ventilated after a while. And here instead, after a lung transplant, you can see that if the CT scan shows that the emphysematous lung is well nice aerated, however, the ventilation is actually only going to the transplanted lung, even though there are some edema showing at the CT scan. So in 2015, we started to have a consultation team at MGH that is based on ICU physician, research fellow, respiratory therapist, ICU nurse, and also an echocardiographer. And these are the three devices that we started. Now we have really actually one entire device that is mounting the three systems. That is, in fact, the esophageal manometry, the impedance tomography, and the cardiac ultrasound. We decided to start to use it because there were many individuals in the ICU that needed and requested, based on prior studies, our prior studies, what was the best positive pressure for these individuals. And the rationale of this is that most of the trials that are out there in the literature, like Arm Express, Alveoli, and LOVES, actually one of the exclusion criteria is class 3 obesity, so BMI more than 40. So we are left without real actually guidelines for these patients. So what we did was to compare in this study those individuals that were ventilated with ARDSNet tables from 2012 to 2014 to those instead that we start to use this method of setting ventilation in hypoxic respiratory failure patients from 2015 to 2017. We enrolled about 70 patients that were based on standard protocols and 50 with the lung rescue team, as we call it. You can see that the BMI of the individuals was about 50 on average in the two groups, and otherwise there was no difference between the two groups. If not, there was a little slightly more hypoxic the patients that were treated by the lung rescue team. The levels of PEEP by the lung rescue team, you see after a consultation went from 9 to 19 on average for day 2, day 3, and day 4, maintained to these high levels of positive pressure. In the ARDSNet group, instead, remained at 9, which was the first setting of the PEEP. Mortality was reduced about half, and we followed these individuals up to 1 year after the treatment and after being discharged from the ICU. We had about less than 20% mortality in the lung rescue team, about 40% in the group that used a standard protocol based on the ARDSNet trial. I think there are 3 possible explanations. So why there was a reduction in mortality? But the first of all was that we treated the individuals with a specialized team, and for sure there was lots of hands-on from our team on these individuals. That of course they could also lead to an improvement in survival. But if you look at respiratory mechanics, it's very telling, because the driving pressure in this individual, which was about 13, was reduced to day 4 about 5, and the compliance, of course, was remarkably improved, while in those individuals with ARDSNet table remained always at 13, and the compliance didn't change. The PF ratio also improved slightly, but not as much as in those patients that were treated by the lung rescue team. One very important question is what happens to hemodynamics. And what we found was that the hemodynamics was very much improved by despite increasing in intrathoracic pressure by positive end expiratory pressure, the requirement for vasopressin was reduced. The VIS score, which is a score of vasoactive drugs, was also reduced, something that didn't change in those patients with ARDSNet table. And I think it's really, so the question is why is that, and why those individuals with higher positive pressures actually counterintuitively were the ones that where the use of pressors was reduced. So for that question, we had to go, and I will present one more study, but the limitation of the present study was, of course, this is still an observational analysis. It's our experience at MGH, but clearly requires a prospective randomized trial that now is in the design stages. And again, certainly we had a clear, oops, sorry, something happened.
Yeah, the slides is went up.
Here it is. I
Yeah.
think it's
Yeah.
okay. Perfect. Sorry. Great. So, okay. So the next question that we asked ourselves was what happened to the hemodynamics in these patients? Why there was an improvement in hemodynamics in patients despite the increase in intrathoracic pressure, despite the increase in PEEP? This is, for example, just from the ART trial, a large trial that was published on JAMA. And what you see here is that the normal, what you would expect, if you increase airway pressure from 10, 20, 30 centimeter of water, what you see in arterial pressure is a reduction of arterial pressure, decrease in venous return, and reduction in arterial pressure. But what we found was that again and again, this is, for example, patients with about 60 of BMI that had ARDS. This was one of our patients. When we increase airway pressure, as you can see, we increase airway pressure, there is an increase in esophageal manometry. The arterial pressure, in fact, followed the increase in airway pressure, suggested that there was an improvement in hemodynamics at higher level of airway pressure. As well as in a second individual, same thing happened to us. This patient had we follow cardiac output, and what we found was that the PEEP was increased from about 14 to about 20 centimeter of water, and the cardiac output and the arterial pressure was increased remarkably. So the question was why? So we did another study, and what we did was to follow these individuals before and after opening and setting positive pressure by recruitment, decremental PEEP trial, and by esophageal manometry. And then also we did an experimental study to understand the mechanisms inside of the lungs. And for the second part, we used a swine model. But let's go for the first part of the study. When we look into about 19 individuals with a BMI of 57 on average that were on pressors, what we found by doing ultrasound is that TAPSI, despite going from about 13 centimeter water to 21 centimeter water, there was no changes, and there was no changes also in S prime, suggesting that the right heart function was maintained stable. And if anything, after the use of recruitment, there was a slight reduction in the use of vasopressors. There was no changes in terms of hemodynamics, the blood pressure, heart rate, and the fluid management didn't change. So the question was why? So what we did was to place in animals. We took some swine. We put a catheter inside of the right ventricle and the left ventricle of the swine, and also we put an esophageal manometry, so we could measure the transmural pressure across the right and the left ventricle, similar to what we do for transpulmonary pressure across the alveoli. We did it for the right ventricle and left ventricle. And what we found was that if this is the normal pressures, this is what you see in the first part of the graph, is the pleural pressure that is increased during incremental recruitment maneuver and decremental PEEP trial. And what you see here is that by increasing pressure, there is an increase in transmural right ventricle pressure, which means that there is an increased effort across the right ventricle, and there is a reduction on the left, a reduction of the transmural pressure, indicating hypotension. So that's what is what you see in the healthy control. When we induced ARDS and induced also obesity in the animal by adding weights on the abdomen of the animal, what we found was in fact that there was a reduction of a transmural right ventricle pressure, suggesting that there was an improvement in right ventricle function during increase in airway pressure. So optimizing positive pressure, optimizing lung function, in fact, reduced the transmural right ventricular pressure. And across the left ventricle, in fact, there was the pressure were maintained. So I would say that in conclusion, I tried to address these three problems, which I think are the most important in respiratory physiology when we consider obese patients, is that there are three areas that one should consider. One is the airway closure, because in the presence of obesity, there is a central airways occlusion that one should consider. Second is the formation of a lung atelectasis that is the cause of a reduction in lung compliance and respiratory system compliance in these individuals. And the third, the impact of positive pressure on hemodynamics, which is, I think, that by resuming the respiratory volumes in these individuals, is the cause of improving the hemodynamics in these individuals, which leads to improvement in survival. And with this, I want to thank you everyone for the kind invitation, and I'm happy to answer if there are questions that you may have.
Thank you, Dr. Berra, sir. A wonderful presentation, so much learning there, and real-time experiments. Lovely, sir. So I request the audience to put up any questions that they have. In the meantime, sir, I can just put up some points for discussion. So, sir, in the beginning, you said something about the obesity paradox. So, can you just elaborate a little on that, sir? That in the ICU, literature mentions that even in ARDS, not only critically ill, the survival, is a U-shaped curve, and even the ARDS patients fare better. So, can you just tell us a little?
Yes, absolutely. I think it's so. There is a lot of in the literature suggesting that there is an obesity paradox, which means that patients with obesity are actually, there is a reduction in mortality in ICU. However, this is clearly not true, as shown by multiple large trials and multiple observational studies suggesting that in fact the higher is the BMI, the higher is mortality. And that is due to either coronary artery disease and of course cardiac components, but also pulmonary considerations and the pathologies. So I think it's I think it's a misnomer, and it's an unfortunately that let's say the obesity paradox received such a great resonance in the literature, but the reality is that unfortunately this is not going to help patients with obesity if we continue to talk about obesity paradox. The reality is that in fact they are a higher risk of mortality. So we need to consider that, and it is possible that that sometimes the level of ARDS, that we consider ARDS based only on PF ratio, one could find that there are patients with obesity have much more hypoxia, but the hypoxia is because of atelectasis, and because they are highly compliant, and they could be they could the lungs can be actually reinflated. But in bottom line, I would say that we need to be very consider when we call obesity paradox, which is really not the case.
So thank you, sir. So I think that's a very important takeaway point, that there is no obesity paradox and these patients should actually be treated with much more care. So that is very important, I think, take-home message. So then moving on to patients with ARDS, obese patients with ARDS. So ideally, sir, if you have to set PEEP, one should have esophageal manometry and pleural pressures. That would probably be the best. But is it okay to kind of, say that we can go on increasing PEEP carefully and look at the blood pressure? So when we cut off, we stop where the blood pressure starts falling. Is that okay in cases where we're not able to oxygenate properly?
Yes, so it's a very good question, and we have to be very careful for a hemodynamic point of view. I agree with you. We have to be very considered. At the same time, we also needed to make sure that we are able. That's the reason why I'm not using only one technique, not only esophageal manometry or not only electric impedance tomography, or we needed to consider hemodynamics, as you suggested, together with respiratory mechanics. So I think that a very, very cautious approach, like you said, increasing slowly positive and expiratory pressure, determining whether there is a reduction in driving pressure, and therefore also following hemodynamics is the right approach. Sorry.
Thank you, sir, for the answer. So then, when you prone these patients of ARDS, as you have to do sometimes, what kind of a position is best? There's you can suspend the abdomen or you can have a reverse Trendelenburg. Can you give any comments on that?
Yes, so good question. So obesity depends on also, as you know, central obesity or peripheral, or there is more abdominal, chest, or hips and legs. So it's very important to determine what kind of. BMI it's a global parameter, but one should really consider the obesity of the individual. Sometimes, when you do reversal Trendelenburg or head up, sometimes actually the abdomen can be squeezed against the diaphragm, and sometimes instead is the opposite. So one should really careful treat the single individual. Another aspect that we don't really talk about was the use of prone position in these individuals. Prone position, we actually we really suggest the use of if a patient has ARDS and is hypoxic, obesity should never be a problem for proning patients, an objection to prone patients. Patients with obesity should be prone. We did a nice video for the New England Journal of Medicine, how to prone patients with obesity. And the reality is that many times patients with obesity can recruit much more by just proning than with the ventilator itself. And the reason why possibly is that the posterior part of the region of the lungs are clearly the larger portion of the lungs. And just proning, you can recruit larger size of lungs in the prone in this patient. So it's very important to be careful, and maybe not just to do in one or two or three. Sometimes you need more hands-on, 3 or 4 people for be carefully to prone these patients. But I highly suggest one of the first things to be done for patients with ARDS and obesity is to prone them.
Thank you, sir. So then final question, sir. When you have ARDS, in normal patients, we look at the plateau pressures, the driving pressures, the mechanical power, and kind of, individualize the event settings. So in obesity, is there any guidance, sir, in ARDS patients, what kind of ventilatory parameters and settings you should follow?
Absolutely. So I would say that what you suggest is absolutely what we do. we use actually driving pressure and either compliance or elastance, but and power. But they say it's the power, lung power. It has an one should consider also the esophageal pressure, because it's not the plateau itself, but is the transpulmonary pressure that one should consider. Otherwise, you get a large power only because the PEEP is elevated. But one should consider the transpulmonary pressures in this case. But otherwise, driving pressure compliance is perfectly fine. And
Right,
plateau
sir.
pressure, this is what we do.
Great, sir. So thank you, sir, Dr. Berra, sir. It was wonderful listening to you, sir. Very enlightening. And I think a very important point, sir, is the first point, the obesity paradox, which is driven so firmly in the literature. Even today, you read anywhere. I think that should be a very important take-home message. And all the important experiments that you have shown to us, wonderful, sir. And I think it is great learning for us. And we are honored today, and we are very privileged to hear from you. Thank you, sir. Thank you so much from the bottom of our hearts. Thank you very much.
Thank you so much. Bye-bye.
Bye-bye.